So this is the Rural Urban Panel. I did ask Helen to try to deliver me 2 mice this morning, one with a cowboy hat, the other with a baseball cap, so we could do Country Mouse, City Mouse. But she has failed to get those mice for me, so we'll see what we can do for later. Just quickly before I turn it over for the panelists to introduce themselves, tell us a little bit about the organizations and the overlap with oral health in their settings. I am Sean Boynes. I, as Helen said, am the director of Harmony Health Foundation, which is a nonprofit, a national nonprofit out of San Diego. And just to give you a little background of why I'm moderating, started my career going to dozens of practices throughout the city of Pittsburgh, providing alternate anesthesia services, and then left there to go serve in a very rural area of South Carolina, literally in a double-wide trailer in the middle of a cotton field, and that is literally the piece. So I was the city mouse and country mouse of this process. I will be your Alex Trebek today, just so you know. I had already promised the panelists I would be more Alex Trebek and less Steve Harvey so that they would shine through the process. So I will turn it over to them to introduce themselves, give us a little background and where their work overlaps.
Hey everyone, good morning. So I'm the city mouse. I'm Kari Hexem. I'm the Chief Clinical Officer at Philadelphia Fight, which is a federally qualified health center and aid service organization in Center City, Philadelphia. We are located in the center of Center City, Philadelphia. We're in the Gayborhood, which is the historic neighborhood in Philadelphia for people who identify as members of the community. And Philadelphia Fight was founded as a field site for HIV research in 1990. And we opened medical services in 2000. We started just with a very small HIV primary care practice. And then in 2014 became a federally qualified health center. Many of the aid service organizations were encouraged to become federally qualified health centers as part of the Affordable Care Act. And so Philadelphia Fight became a federally qualified health center at that time. And as part of becoming a federally qualified health center, we had to really secure our patients and clients with access to dental services in a new and more meaningful way. And at that time, I very fortuitously had been interning at Philadelphia Fight. I was a student at Penn Dental School. I worked with Dr. Shamlu and also Dr. Glutch. And Dr. Glutch really supported me in developing my relationship with Philadelphia Fight. We wrote a few grants that were funded by the Independence Blue Cross Blue Shield Foundation, and we opened up a dental program at Philadelphia Fight in 2015. And because all of you know the need for dental services is so great, we had been open less than 6 weeks before I hired a second dentist. I hired another dental student who was graduating in the summer of 2016 who was looking for a job in Philadelphia. And we've grown and flourished since then. And I'm happy to be here today. I will say that I spent so much time just focused on my organization, and I don't even think about Philadelphia that much. And then I get on a train and I'm like, oh my goodness, there's this whole state of Pennsylvania. And I actually really like coming to Harrisburg. It's like a beautiful train ride. It's very relaxed, so quiet. But yeah, I'm the city mouse, definitely.
Excellent. I'm feeling like a rock star here with a microphone. My name is Laura Dimino. I work at the Center for Rural Pennsylvania. We are a legislative agency that was established in the 1980s by the legislature. So we are a legislative appropriation. And our job is to inform the legislature and other aspects of government as well on issues of importance to rural areas. In the process, what we do is we collect data, a lot like our previous presenter Amanda, who was awesome today. We collect data. We're mandated to do that, and we collect it on both urban and rural areas for the sake of comparison. And we provide that to the legislature. So we do internal research, reports, and literally print it and ship it off to put it in front of legislators' eyes and their staffers. And our second mandated purpose is to do research and to fund research for faculty at public institutions in the state. So always going around, talking to people and saying, where do we need more research? What can we fund? What is an important issue over the next year? So truly, if anyone has ideas that we can help fund, let us know that. Let me know that directly. Yeah, so we also spend a good deal of time. We organize hearings. We spend time as a group, as our staff, getting to know people and understand a little bit about every policy area to understand what the important issues are at any given time. So we will take turns attending conferences like this to really get a handle on what the major issues are. So thank you so very much for all the great information that you have provided during this. And I will just say, just for point of reference, in the state of Pennsylvania, it is a very large state with 67 counties. Our rural counties are about 3/4 of the state. There are 3.5 million people living there, and that is about the size of Utah. So we have a state within a state, and very dedicated to trying to find policy solutions for everyone in the state.
Thank you both. Dr. Dimino, will keep your microphone on and ask the first question.
Sure.
How do transportation issues such as lack of public transportation or office location in rural Pennsylvania affect access to care for patients?
Transportation, I think, in rural areas is a different, sort of thing than urban. If you're living in Philadelphia, you're dealing with more available public transportation. Even within Harrisburg and, of course, in Pittsburgh, our heavy urban areas are on either side of the state. As with most things, this economy of scale. Right, so you've got very few individuals living in small towns scattered throughout over 40 counties. There isn't the incentive necessarily to provide regular transportation to people. Just to give you an idea, we've got about 7%, almost 7.5%, of rural residents do not have their own vehicle. In urban areas, that's a bit higher, but again, in urban areas, there's also greater accessibility to that. So we know that if you look at county level government throughout the state, there's a good deal of funding dedicated toward creating shared rides and other kinds of options, which again are sporadic, right? They're not regular. They have to be arranged. People have to apply for them. There are some barriers to that. So we see that for older members, older residents in the states. People of limited income can qualify for some of that transportation, but it does become an issue.
Dr. Hexem, when you hear about the transportation issues that sit in rural, what resonates for you from an urban standpoint?
I said this when we did our little pre-call. I really am in awe of all of the challenges that are faced by rural clinicians and organizations in trying to serve, because I do feel like the barriers are enormous. Transportation challenges exist in cities as well. The transportation systems can be unpredictable. We were very nervous about a SEPTA strike happening in October, and I was like, I don't know what we're going to do if we have a SEPTA strike. We got to reconfigure all of our expectations around people showing up for appointments. And the transportation systems can be confusing, so people don't necessarily know how to get from where they live. Even though we are, as I said, we're located in the center of Center City, almost all of the transportation, bus lines and train, everything comes within a close radius to us. People still have a lot of challenges navigating our systems, and especially if they have language barriers. And so oftentimes people will spend more Ubering to our practices than they spend on whatever their sliding fee amount is for their visit. And also ride services. So if people do have transportation that is dropping them off and picking them up, oftentimes those services themselves can be unpredictable. So we'll get calls, I'm running late because my ride never showed up to get me. I have to go because my ride is waiting for me, and if I miss it, they're not going to come pick me up again. So I think those are some of the transportation issues that we have, even with transportation.
Thank you. Dr. Dimino, I can relate to the next question. I just recently moved to a more rural location, and some days my cell phone has a bunch of bars. Some days I am praying that I'm not going to drop off of my Zoom calls. And so I'm wondering if you can talk a little bit about the persistent issues with broadband access, and maybe even touch a little bit on cell phone reception that maybe we don't talk about as much.
Right. This continues to be an ongoing, I think, concern in the state. I'll just briefly mention cost as well. So first we've got the cost of really effective broadband. So assuming you have infrastructure and have the capacity to connect, the question is, will you have the income? Does everyone have the income to do that and get the best quality? But leaving that aside, the state is in a position to get over $1 billion from the federal government to help address this issue and increase access throughout the state to the infrastructure that allows unserved areas, right, to get that. So in thinking of that, that sounds really awesome. If I think, someone gave me, over $1 billion, the things I could do with it. In reality, I think right now the concern is that's not going to do it. That's not going to solve every area. Because really, if you think of how large the state is, the cost of labor, the simple practical, right, problems involved in getting it everywhere, it may not solve all of those issues. There's a lot of promise and not necessarily that. I think the concern with this overall, right, is that it compounds other issues. So, let's just go back to dental health for a moment. Dr. McDaniel talked about bringing dentists into areas that are underserved, some of which are rural. Do you, as a healthcare professional, you've gone to school, you have a family, perhaps you want to start a family, or, you're going to move to a county where there's no broadband, your cell phone doesn't work, you can't access great housing. Necessarily, we don't necessarily have the kind of grocery stores you're going to see in an urban area, et cetera, and so forth. Broadband is just something on top of all those things, but these things overlap to, I think, cause great concerns for rural areas. So we are seeing progress. I'm not quite sure that we're going to get to full accessibility, though, even in 5 years.
Thank you. Dr. Hexem, changing it up here just a little bit. So we have increasing populations, especially in Philadelphia, of non-English speaking individuals. How can dental providers best accommodate their patients? And is there a larger push for bilingual staff? And is there pressure to increase hourly pay for those individuals?
Well, first of all, you need to have a differential to acknowledge your bilingual staff. If you're asking staff to provide interpretation and translation services, they need to both be trained and compensated, and it needs to be in their job description. So that's easy. That's a must. The Dean Wolf at the dental school would talk about must statements. Like, that's just the law. And I know it doesn't always happen because kind of tradition is that we just, we hire someone who's bilingual and then we pay them the same as we're paying everyone else, but then we ask them to do this additional labor. But there are protections and standards there. And that makes it very easy when you're going to your administration, because you're just like, no, actually, we have to do this. This is not just like a nice thing. This is a must. And it's really very helpful to have bilingual staff. I mean, Language Line with the video is pretty good. I like it, especially for like my Polish-speaking patients and my Korean-speaking patients. Like, you're not necessarily going to have every single language represented in your clinical teams, but I think at FIGHT, and we have some other people here from Philadelphia FIGHT right now, but I think about at least a third to half of our clinical staff is bilingual. And my Spanish has actually gotten worse over time because I don't use it as much, because we end up relying on our bilingual team members.
So sticking with you, Dr. Hexem,
Get language line on your phone.
you can?
Yeah, there's an app.
Okay.
There's an app for that.
There is an app for that, folks. That's great. How can providers make their space more welcoming and comfortable for LGBTQ plus patients? And given your location and where you're at, I think you can offer a lot of insight for the group.
So I think signage can be very welcoming. We basically just like decorate with rainbows everywhere. We had this great whole wall of love is love with rainbow colors that one of our team members put up a couple years ago, and we just left up for years and years because it was such a warm and welcoming way to have the reception area. And I also think I love hiring people from the community. People are really inspired to come work at Philadelphia Fight, and I think that I'm able to recruit people that I would not necessarily otherwise be able to recruit to a community health center because they are gay or lesbian or queer, and they just love being a part of a space that is so welcoming. And so, again, I think that people with lived experience is another way to really create a welcoming environment.
Did it become automatic, or do you have to sort of continue to work at it as the staff? If the staff changes, like how did you maintain the culture that's there? I know this is an added question, but I'm just curious, like how were you able to maintain it and not have it drop off, or maybe it did and you had to do something to kind of galvanize it again? What's the secret sauce, I guess?
I think cultures can be self-perpetuating, and I think that can be true for positive as well as negative workplace cultures. But our workplace culture is so queer affirming at this point that that when we post positions, we get people who come and they're like, "Why do you want to work here?" And they're like, "Because this is like a friendly place to work." And that's true not just for our dental practice, but for our medical practices as well. And it's imperfect, right? Because people have differences, and people can say things that are thoughtless in an attempt to be friendly, and that can happen. We have people from a variety of marginalized communities working in our practices, and so there can be differences across communities, and so I think that you want to assume good faith, but you also want to have trainings. We have great trainings done about pronouns and gender identity, and so all of our new staff participate in those trainings so that we all have a kind of shared vocabulary about sexual and gender differences. But that's important for racial differences and language differences as well as even age differences. Honestly, people are people everywhere you go, and there's a lot of difference in the world.
Well, the low-hanging fruit here, no pun intended, I guess, is in K through 12, right? So through our public school districts, assuming young children are attending, we have access through nutritional programs, and we see in talking with superintendents across the state in rural counties and school districts, they are increasingly providing meals to the students in their population even when school is out of session. So we see an increase in the number of meals per day, and an attempt to make this year-round because there is such a need. I also know I last summer attended the PARS conference, Association of Rural and Small Schools, and superintendents there were talking about the new regulations, right, regarding menus, right, the school menus. So I think, here we have an imperfect solution. We've got the state trying to regulate what is served to children in an effort to make it healthy and ensure children's health. And at the same time, you can hear people talking, right, down in the trenches, as I say, like, kids aren't eating that stuff, kids aren't eating that stuff. So I think there are a lot of efforts being made to try to ensure that, but also have to make sure that students are eating that. With regard to the overall access, to families, again, it's a compounded issue simply because of lack of access to fresh fruits and vegetables, grocery stores. If the dollar store is the most convenient place for you to shop, your selection there, right, is extremely limited. So I don't think we have a very easy policy solution for that, unfortunately.